Hello and welcome. My name is Jennifer Roeder. I'm a communications consultant for APFED, and I'll be moderating today's webinar. Today, we'll learn about transitioning from pediatric to adult care from Dr. Kristle Lynch. Dr. Lynch is an associate professor of clinical medicine and currently serves as the director of esophageal and swallowing center of the University of Pennsylvania's Perelman School of Medicine. She's also the founder and program director of the Advanced Esophageal Fellowship and the director of the GI Physiology Laboratory. Her clinical and research interests include eosinophilic esophagitis, esophageal motility disorders, and gastroesophageal reflux disease. Welcome, Dr. Lynch.
Thank you so much. Just going to share my screen here.
It looks great.
All right, great. Thank you so much, and thank you to APFED for inviting me to speak today. APFED has really been an absolutely wonderful resource for us physicians and helping take care of our patients. As mentioned, I'm Kristle Lynch, the director of the Penn Esophageal Center over in Philadelphia, and today we will be discussing EOE transition of care. And my disclosures are listed here. So there's no better way to start than with EOE, as probably everyone on this meeting is aware of. EOE is an immune-mediated condition characterized by eosinophilic infiltrate. And we know that this disease can lead to chronic inflammation, which can lead to dysmotility of the esophagus as well as dysfunction. And the classic symptoms, in adults typically include dysphagia, heartburn, as well as food impaction. And we know that this diagnosis, when suspected, is really confirmed on histology, on biopsy of the esophagus with over 15 eosinophils per high power field. So when we say dysphagia, what does that mean? Classically, that means trouble swallowing, but patients will often describe something different, right? If you ask a patient, do you have trouble swallowing? Sometimes they'll actually say no, but there's food sticking in the chest. They feel the food moving slowly, and sometimes have regurgitation of food, especially after a sensation of food getting stuck. And that, is really pertaining to adults. Remember that symptoms in children are widely variable. And, I'm an adult gastroenterologist and I only treat adults, but I'm very sensitive to the fact that symptoms in children are very different. You'll often see just feeding dysfunction or lack of weight gain, abdominal pain, vomiting, as well as some of the more classic symptoms that adults have. And so now let's talk about healthcare transition. What is healthcare transition? So it's the purposeful, planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered to adult-oriented healthcare systems. And so there's a lot of sort of powerful words being used in this definition that was given in a paper by Blum et al. But it's not just a transition, right? This is purposeful and planned, and overall changing the focus of the responsibility of the healthcare of someone with a long-term condition from child-centered to adult-oriented. Healthcare transition actually can start as young as 12 years of age, which is often surprising. People will typically think of, oh, there's some sort of quick transition at age 18, but the actual process of transitioning can start as young as 12 years. And providers need to provide disease-specific knowledge and many tools for those with chronic diseases. And we'll talk about a lot of those tools and steps today. This really helps build independence on behalf of the patient, as well as less reliance on family members and family support. And so overall, this is really a shift from caretaker-centered to patient-centered responsibilities. So now looking at specifically transition of healthcare in EOE, this is, a unique transition. EOE is a long-term allergic condition. And we know that patients do best when they're on therapy long-term, right, for their entire life. Doesn't mean they need to necessarily be on the same therapy, especially in patients who have had the disease when they're younger. Life situations certainly change. And then when they're an adult, their life situation may certainly change just within the realm of being an adult. And I have plenty of adult patients who transition to different therapies throughout their disease course. So we think therapy is key, but not necessarily the same therapy. Also, with EOE, there are some unique barriers that many other chronic conditions don't have. So, endoscopic procedures, an invasive procedure that requires anesthesia, and there's risk. Um, and as I often tell my nervous patients, it would make sense to be nervous before an endoscopic procedure because you have, a essentially a stranger putting sort of a foreign device in you, and you're trusting them um, while you are asleep. So there's a level of trust that is sort of required when patients specifically have a chronic disease that requires endoscopy. Additionally, EOE is unique because of the multidisciplinary nature of the management. We have GI, allergy, dietitian listed here, but there are often other disciplines that also interact to take care of the patient. And so your team is different in EOE and your team is more complicated. And that is a unique barrier for the transition of healthcare in EOE. Let's look at what patients are saying. There was an APFED transition of care patient survey, an online survey. 41 teens and young adults took it, and they had eosinophilic disorders. So EOE, EOG, eosinophilic gastritis, and colitis. And 95% of the patients who responded were first diagnosed by a pediatric gastroenterologist, and the majority of respondents were still under care of the pediatric gastroenterologist. Of these patients, it was a biased group, with 100% of the patients having access to a computer, smartphone, or tablet with internet access, which is how they accessed the online survey. And I won't go through all of the responses, but I did want to highlight that one of the questions asked was, at what age do you plan to transfer you or your dependents' care from a doctor specializing in pediatric patients to a doctor specializing in adult patients? And so there's sort of age ranges given. I'll let you think about it. The majority of patients responded between 18 and 21 years old. And so they planned to transition their care when they were between 18 and 21 years old. And it looks like about over 80% of the patients total were in the age range planning somewhere between 18 and 26 years old. But then a follow-up question in the survey was, have you had conversations with your healthcare provider about transferring your care from a pediatric healthcare provider to an adult provider? So you'd assume that if we know what the goal was, that many of the patients coming up to the age of 18 would have had these conversations. But here you can see the results. So 31% of the patients who are between 15 and 17 had conversations. Only 31%. 67% who are 18 to 21 years old, and all of the patients who were above 22. So let's talk about the transition of healthcare in EOE and the general transition program elements. There are many elements that we need to keep in mind for transition of care because it's a complex process. So is the patient flexible and developmentally appropriate for transition of care? And this really should, as we already said, should be initiated early. That doesn't mean that the transition is occurring early, but just the process is initiated early. But we have to allow for individual timing when patients can function autonomously, and that is different for each patient. Slowly, we should start increasing the patient responsibility, their own power for decision making, and their autonomy. And I think with that, there should be parallel support, right? So we should really encourage peer support through mentorship, support groups, and transition clinics. And, with the advent of the internet, certainly online support groups can be very helpful. With transition of care, a dedicated transition coordinator is really ideal. This would ideally allow for an individualized transition care plan, right? Really tailoring to the patient's timing, maturity level, and disease. Additionally, this person could monitor progress of adolescents as they transition and support the adolescent through the transition. And I mean through. Even after they transfer to the adult clinic, it would be ideal to have someone dedicated to stay with the patient and follow with them and check in. Additionally, this transition coordinator really should help schedule appointments, inquire about missed appointments, and really educate and encourage um, about the disease as well as career planning. It's tricky because uh, patients, as they become adults, will go through a lot of career transitions typically. And that in itself is already a challenge. But to additionally add in, all the things that come in with healthcare throughout their transitions in their career can add an extra hurdle. And this dedicated transition coordinator, if available, would also facilitate communication between provider, patient, and caregiver. Because caregivers, right, like it's hard for us to let go. We always like to stay on, check in, and know exactly what's going on. There are some critical milestones that we should be assessing in transition of healthcare. How well do patients understand their disease? This may seem obvious, but I think there's a difference between a patient understanding how to live with their disease and a patient understanding the pathophysiology of their disease. Also, are patients aware of the effect of their condition on their overall health and life? Has the patient demonstrated responsibility and ownership for their health care? And have they actually stated readiness to transition to an adult provider? You know, as an adult provider, I can say that pediatricians are a lot nicer than we are and really wonderful. My pediatric colleagues are the best. And so it wouldn't surprise me that it might take some time for someone under pediatric care to state readiness to transition to an adult provider. Um, and are they able to maintain their personal medical records? So, regarding demonstration of responsibility for their healthcare, do they demonstrate that they're able to understand their medications, know when their medications are timed, know when their refills are due? Um, are they communicating their healthcare needs and understanding how to triage their own symptoms, knowing when they should seek urgent care or when it's not urgent? And that's a challenge for anyone with any medical condition to understand, but that's a very important part of their care. Can they make appointments? Can they keep their appointments? And do they understand insurance? Regarding maintenance of personal medical records, whether that's paper records, we have patients coming in with a tabbed binder by year, by disease, by symptom. That is wonderful. We have patients who have electronic records, and that is wonderful. Now, with the advent of electronic medical record, many patients are able to interact on their phone with their portal to see their own electronic records. But additionally, some patients keep personal notes, right? Because the notes in the electronic medical record may not fully reflect everything the patient is feeling, right? It may reflect the testing that they've had, endoscopies, biopsies, imaging tests, and lab tests, but patients often will keep personal notes and their own timeline for what they were doing when. And I've had patients come in with no physical or electronic records and have it all in their head. That is wonderful, impressive, and absolutely fine as well. But the question is, this milestone is maintenance of personal medical records in whatever way is best for the patient. And there's two types of important education. Actually, there's more than two, but there's two that we'll discuss here: patient education and caregiver education. So it's interesting. Patient education is very obvious, right? Materials geared towards the patient at whatever developmental stage they're in, that's appropriate for their maturity level and their intellectual abilities. And it would be ideal if these materials were available in a variety of formats, whether, some examples listed in this article that I'm quoting were comic books, pamphlets, web-based or slides, etc. But caregiver education, addressing that your role as a caregiver is evolving, right? It's hard enough to sort of let go of our kids and let them fly, but that your role is evolving and perhaps intentionally peeling back and will allow the patient to take more ownership and more autonomy of their own healthcare. And that's hard to hear. And I think it's important to educate caregivers. Um, Additionally, as caregivers, we need to provide instruction on preparing adolescents for their adult role, reminding them that you are taking an adult role in your healthcare. You will be primarily the person in charge of your healthcare. Your healthcare will be centered around you as the patient, and you yourself will be your own caregiver. There's also provider education for us as physicians, so both pediatrics and adult providers. I think that I wish that there was more intentional education towards providers on this, but key concepts are introduced during our residency training, and additionally via CME or continuing medical education events, such as grand rounds at the University of Pennsylvania, it's an example, or our large GI meeting, Digestive Diseases Week. We are seeing these concepts introduced and discussed. Additionally, it would be ideal to develop transition clinics. So these are described as these joint adult pediatric visits with longer time slots. In an ideal world, I think that would be wonderful. We'll talk about some of the barriers to transition next. Additionally, for provider education, I think that it is key to facilitate collaboration with providers in other specialties, especially for EOE. This not only allows us to understand the patient better as a whole and to understand other organ systems, but also this helps us pool and increase resources. At Penn, I think sort of one example of how we interact in sort of the EOE world is our relationship with the allergists. We have trainees from allergy in the GI clinic. We have trainees from GI in the allergy clinic with ENT, learning from each other and having that collaborative relationship. And I think that helps the patient have well-rounded care, better communication between providers, as well as overall an increase in pooling resources. So all of these things, I think, sound great. I think that there are many steps to transition of healthcare, but we need to recognize that it's not always easy. So what are some of our barriers to transition? So it's interesting looking at articles written about this and studies done on barriers to transition, because the first barrier is listed as normal adolescent behavior. Parentheses, rebellion, apathy, and maturation. So already your patient population is starting you with a challenge. Normal adolescent behavior is a barrier to transition, and I think it needs to be out there and recognize that that is normal. Additionally, in general, we see worsened adherence during adolescence, and so that can be an additional challenge. Remember that these are patients with chronic diseases, so developmental challenges from chronic illness is also a hurdle. And what is the appropriate level of caregiver or parent involvement? This is tricky because if you ask any adolescent, what is the appropriate level of parent involvement in XYZ, right? In your sports team, in your play, in your schoolwork, it's extremely variable. They have their own opinions. So what is the appropriate level in healthcare? It's a very, very fine line to walk with an adolescent. And we had touched on this before, but comfort with a pediatric provider or potentially resistance to an adult provider, that certainly can be a barrier. What about provider-specific barriers? So there can be a lack of training if adult and pediatric providers in transition of care, insufficient communication between adult and pediatric providers. And additionally, adult providers, we are very inexperienced with adolescent and child development. We see adults all day. We are only board certified in adults. So that's certainly a barrier if we have not had the education regarding transition of care. Additionally, I think that when patients have rare diseases, sometimes it can be challenging to find a adult provider who's comfortable treating that disease within a reasonable radius of the patient. And so that certainly is a barrier to many diseases, many rare diseases. And then, you know, we need to talk about systemic barriers. There's a lack of exemplary transition programs, a lack of resources and funding for these coordinators. Sometimes we see these abrupt transfers of care without appropriate mental preparation or transition of medical records. In the United States, this is a problem that we really cannot see medical records from other centers, even centers perhaps down the street from you. If they are not linked electronically, it is very difficult to see the records. And so patients have to turn to faxed records, paper records, and I have patients who come in with a stack of records just in case uh, they were not received by my office. And that's certainly a challenge because typically providers, when they're receiving new patients, do like to look at the records in advance. Inadequate reimbursement is certainly an issue. Transition services, having longer combination appointments, for insurance companies, oftentimes is money. And so having less reimbursement does not motivate practices to have transition services. And also we see a loss of patient insurance coverage when the patients are transitioning from a parental plan or Medicaid. Additionally, there is the requirement in EOE for multidisciplinary collaboration, and that can certainly be a barrier. It can also be an extra hurdle in the sense that you have this checklist. Oh, I transitioned to my new adult doctor, I have that appointment. But what about the nurse, dietitian, psych, social work? All the other aspects also need to transition. So let's talk briefly about barriers to transition in real life. This is an online survey of caregivers and patients with EOE. And there were 67 respondents, and 91% of these people were under adult care at the time of survey completion. So the main question I wanted to highlight is, what were the patient's biggest struggles as they transitioned over to adult care? The main ones were meal planning, food shopping, cooking, and insurance coverage knowledge. And it's interesting, if you look at patients who are in general transitioning to adulthood without any medical problems, they also struggle with meal planning, food shopping, and cooking, as well as insurance coverage knowledge. If you add on a complicated limited diet on top of that, if you add on symptoms like food getting stuck, foods with certain consistencies, requiring a certain diet, they will struggle even more. So this certainly makes sense. And although most of these patients actually reported some confidence in managing their EOE, almost half of them did worry about future management. So what are some resources that we have to help you through this very difficult time? APFED is a great resource. I'll highlight here their main website. On the left, I clicked on the resources tab for patients. And sort of zooming in here, there's a list of different links that patients can click on, including strategies for everyday living. And so I thought this was really nice, sort of adults living with ages, surviving social outings, dining out, cooking for family. And this is a good time, November and December are probably the two most challenging months for my EOE patients, especially those on dietary therapy. And the tips that, patients often use, I call it my patients tips to patients from patients. This is what patients tell me, and I pass it on to other patients. And they're posted on things like the APFED website, but pre-eating, right? Always pre-eating safe food, bringing your own food, no cheating, having a bar in your pocket, but just being fully prepared. And so some of my patients will actually prepare like around Thanksgiving. They'll just stock up on safe bars and they'll take those to social events in their pocket in case they're hungry, and they'll usually pre-eat. But these are very challenging months, especially for patients with allergic diseases who have limited diets. I'll also highlight here the specialist finder. So we had talked about how challenging it can be to find someone who treats your disease in your area. The APFED specialist finder, which is off of the main website, apfed.org, does allow you to put in the age of the patient and the specialty that you're looking for and the area, and it comes up with a list of providers with the information for scheduling with them. Or you could always just look up their name on Google, on the website of the practice as well. And I don't know if you know about gottransition.org, but it's actually a resource for transitioning from pediatric to adult healthcare. So this whole website is actually dedicated towards this. They have 6 core elements of healthcare transition, and they have tools and sort of toolkits that are tailored towards youth and young adults, parents and caregivers, and then they have resources and research as well. You can see here some of their sort of top resources. So there's a family toolkit, which sort of encompasses the pediatric to adult transition, and then other tools to learn about transitioning to adult care. They have everything from like articles to infographics to video. So kind of what we're talking about, having varied resources for the transition of healthcare. So just a brief practical caregiver and patient timeline. This sort of doesn't summarize everything, but I wanted to point out things sort of in a nutshell. So initially when you or your child is diagnosed, really educating yourself on the disease. And when the child is younger than 12, really familiarizing yourself with the treatment schedule and working that into your child's life. Around age 12 to 16-ish, the pediatric team may introduce the transition of care timing with the patient, or they may not. The pediatric team really is the expert in when to introduce this idea. And then as patients get older, they may start seeking out and utilizing these transition of care resources. Eventually, we need to make these appointments, transfer records, transition responsibility. And then eventually, as the patient is transitioned to adulthood, of course, continued check-ins and support. And I just want to summarize that we can do this overall as a community. Thank you so much for listening today.
Thank you for such a wonderful presentation. I really like some of those graphics that you put together to help people really visually understand the transition plan. All righty. Well, now everyone that's on here with us, we are ready for our Q&A portion of the event. So if you'll click on that Q&A tool at the bottom of your screen, you can go ahead and start entering in some questions. But to start, let's talk a little bit about what are the basic treatment options for EOE in adults.
Yeah, so for treatment options in adults, we do have some overlap with the pediatric therapeutic options. You know, the main categories I think of are diet and drugs. And there's also dilation. So kind of like 3Ds, the letter D. Regarding diet, they are similar to the pediatric diet options, including elimination diets, whether it's 1 food, 2 food, 4 food, 6 food, step up diet, etc. Adults rarely use the elemental diet. And as you're probably aware, the allergy guided diet has fallen out of favor and has not been shown to be significantly beneficial to our EOE patients. Regarding medications, technically it's off-label use for proton pump inhibitors, as well as topical steroids, but those are widely used for EOE in adults. And then Dupixent is the only and first FDA-approved injection medication for EOE that's given once a week. Dilation is not as often done in children, but it is more present frequently, and strictures are more present or narrowing. So dilation is used more often in adults, where the endoscopist will decide whether or not a stretching or dilation of the esophagus would be helpful or is needed. And that's usually decided during the procedure. And so for dilation, if the patient does need it, doesn't mean they'll need it in the future. They could, but it's still important to make sure you're on track for either medication or dietary therapy to prevent the narrowings in the future. So certainly some options for therapy in adult EOE patients.
Thank you. Appreciate that overview. So you talked a little bit about how transition can start as early as age 12. What age do you start treating patients as an adult for EOE?
Yeah, it's tricky because the transition is really decided. I always defer the time of transition to the pediatrician. They know their patients the best, but technically I only see patients 18 and over. However, we have a lot of transition patients from CHOP, the Children's Hospital of Philadelphia, and the age range of transition is pretty varied. It depends on the patient's developmental level, other chronic medical conditions, um, and really when the patient is ready. We do defer that decision to the pediatric provider because they know their patient the best. But I notice they also will try to transition when it's maybe the disease has sort of is quiescent, or there's not a lot of transitions going on in the patient's life at the same time, whether it's changing schools, moving across the country, moving jobs. There's a lot of transitions for patients. So I've noticed the pediatric providers try to really minimize the number of simultaneous transitions, and we're pretty appreciative of that.
It's certainly a very transitional phase in life, that's for sure. So once a child transitions to an adult provider such as yourself, how can a parent be involved with their child's care?
Yeah, I mean, as an adult provider, I love when the patient's parents are there. I think for the first visit, when you are meeting the patient and trying to establish a relationship and really establish that trust, it's nice for the patient to have support there. Also, if the patient has never been to a visit alone, which is often the case, I think it's nice to have a slow movement um, of sort of their healthcare overall. Typically, we try not to rock the boat too much during the first visit, but it is really nice to have that extra set of eyes, ears. And I always ask whoever the patient is with, actually, typically for my adult patients, not even adult patients who are transitioning, but any new patient, whoever they're with, I ask them, is there anything else or anything else about the symptoms that I need to know? Because the person who cares about you and who's with you often has some critical information that maybe you didn't have the insight to really say about yourself because you're so used to living with it, right? But your family member is like, "No, this isn't normal. What's happening and what I observe isn't normal." And they usually will contribute some key information. I think there's a couple other key things for the parent to assist with in the beginning. Having the past medical records are key, and they can be quite challenging to get. Patients these days are very savvy, especially if they have an interface electronically with their medical records. But if not, it can be very challenging to get all the faxed records. Parents and caregivers also often keep a nice paper trail. And so copying that, bringing that, faxing that yourself ahead of time can be very helpful. But I do think the extra set of ears is very nice too, because there may be a lot of new information that the young patient is receiving that they've never heard before.
Are there any forms that the adult patient would need to sign to allow the adult provider to continue be a part of the care?
Yes, yes, because the adult patient is an adult. And so the first call, this is hard, it's a transition. The first call is the patient. It's always the patient. But different centers have sort of different forms, but it's usually you have to allow us to discuss your healthcare with your XYZ, whatever, whoever you have with you. Um, Relative, non-relative, doesn't matter. Usually you have to fill out that form. And some patients will say, can you call my parent first? I tell them, I can always call your parent if you allow me, but I will call you first because I think it's important that you know it first. And if you don't want to write anything down, take any notes on what we talk about, that is fine. I absolutely will call your caregiver next. But I do feel that I should talk to you first. And that is typically the rule once you're an adult. And so I think that can sometimes help with the transition, but we're always happy to make two calls if needed. But I don't like leaving the patient out of the loop, especially when it's an adult patient.
So, if you are a caregiver and your child has reached that age of 12 and they are continuing with their treatment and they're not hearing anything about transition of care from their provider, at what point should a parent start that conversation or even a child?
Yeah, I mean, that's a great question. I think that some parents will reach out to the pediatric provider and make that intentional step. Can we talk about this at the next visit? Or why aren't we talking about this? Like, do you have a secret plan that I don't know about? Maybe you don't think they're ready and you wanted to talk about it later, but keep me in the loop. The other thing that can be done is bringing it up at the visit, right? So, oh, thank you for, we're doing all this. This is the plan, but what about the next steps? What do you think? Asking the provider, what do you think about transition of care? And do you have someone in mind? Um, I think that can be very important in initiating the conversation. But I mean, the question in itself is a good point. We need to be intentional about these things to make sure that I think it's never too early to start talking about it. Because it doesn't need to be that way. It doesn't need to be something abrupt.
We've got a nice question that popped in here about kind of a unique situation. So in this case, the caregiver's uh, son's provider has a rule that they can't see patients after age 21. In her situation, in addition to EOE, they have some developmental disabilities. And so he's not able to manage his own care. They're having trouble finding a GI provider that's familiar with EOE as well as other care providers. So they're asking about like, how can you plan for the future when the person becomes an adult and they really can't take care of their own care?
Right?
Certainly one of the things you're asking about is how to find care. And so that specialist finder that APFED has and that Dr. Lynch very nicely shared with all is certainly a great tool to help look for resources. But can you talk about what happens when you take over care for someone as an adult who can't take care of themselves?
Yeah, certainly that can be very, very challenging. And I think there are a couple approaches to taking care of these patients. These patients obviously don't transition. I mean, I guess there's no typical transition, but these patients, it can be very challenging. But adult providers, do take care of these patients, and we heavily, heavily involve the caregivers and parents. And you know, these are patients who it's not abnormal for the message. I know the messages from the portal are from the parents and the caregivers, and those are, the oftentimes it depends on the level of functionality of the child, but the child may not even have their own phone, things like that. And so with patients who are developmentally disabled, there's a lot of communication with the parents and caregivers. If you live somewhere where it's very difficult to find someone, I think it's important in the time that you have with the pediatric provider to come up with the game plan and a lot of if-thens, and then educate your primary care provider to see if they are comfortable with that, right? The adult primary care provider, I understand with subspecialists it's harder, but if they are comfortable managing that, they can be the quarterback physician, and then you may have to make a trip out once a year, hopefully, to see that provider that's pretty far away that is familiar with rare disorders. So I think getting a good plan with a lot of if-thens is very important in the time that you do have with the specialists, and also asking them, do you think this is something that the primary care doctor for an adult can manage with occasional visits to the subspecialist? Or do you feel like this is something where we're really going to have to think about and reassess our lives and center it more around the patient and being closer to someone who is familiar with this disease? And that is, it's very hard. It's very hard. It's a very difficult situation.
You run into situations where the person that's helping this type of patient is not the parent. For example, this parent is concerned about what happens when I'm not around.
Yeah, we have some patients who have other providers or caregivers that are, certainly not the parents. For example, other relatives as well as like medical assistants. And I think that can be difficult depending on the resource level that you have. But yeah, there's no one size fits all. I think that every situation is different, and what's best for each patient can be highly variable.
You touched on earlier about being able to transition records from your pediatric provider to your adult provider and the challenges of faxes versus the positives of electronic medical records. What tips do you have for people that don't have access to a medical record electronically? Do you want them to track down notes from the doctor? Do you want their notes from them? Like some combination thereof?
Typically, they should be guided by the provider that they are transitioning to. So, for example, in our practice, we usually like to see for the past at least 10 years all the relevant clinic notes, which would include a primary care doctor, allergist, GI, dietitian, plus endoscopic findings, plus biopsy results, plus imaging tests, plus labs. But there's actually like a list that they'll give the patient, or they'll just have the patient sign the release form and they will send that over to the referring physician's office. And that office is usually familiar with it. There's typically a group that's in charge of the medical records. But I do think that, I mean, we've all had experiences with the lost fax cloud, where it apparently goes up and it never comes back down. So I think that it's important to follow up and make sure those records were actually sent or received.
Makes sense. In your presentation, you talked about the ideal situation of there being a transition coordinator. Is that something that you have experience with working with?
Unfortunately, transition coordinators, I think, are ideal, but they're few and far between. Um, it's really a lack of resources, I think. And like mentioned, there are many barriers to it. Typically, lack of resources, and then even having like a transition clinic, the lack of time. In general, right now, it's so hard for healthcare in general to keep up with the demand, and so adding in an additional clinic with that's potentially even longer time-wise for the visit is really challenging. But
Makes
I
a lot of
do think
sense.
that a transition coordinator would really make things so much easier. Um, and I think it's important to talk about, right, and ask for. So
Absolutely. You also talked about the importance of education materials, both for patients and for caregivers. What kind of educational materials does your practice provide?
So there's many sort of resources for our patients in general, but typically the education materials come from the pediatric side and on CHOP's website. I think Got Transition is actually a great resource in general. That's the one that I had shown that is for transition of healthcare in general, that is not specific to EOE. Additionally, many of our patients, the pediatric side, we do get referrals outside of Philadelphia as well, but the CHOP GI team is quite familiar with this transition over, specifically with EOE, and hopefully, I think with the experience, it helps make it a little bit smoother. But every patient is a different level of challenge, so it's definitely patient specific.
Yeah. You made a very interesting comment while you were talking about barriers to transition around the worsened adherence during adolescence, in terms of many different aspects of life. How do you help your newly transitioned adult patients adhere to their treatment plans?
I think that it depends on the actual barrier of the patient. Reminding the patient that of where they were before when they were untreated is often effective because I never want them to get there, right? That is the goal. And if this disease is not taken seriously, we may regress. So we don't want to undo all the years of hard work that you have done, I think is one reminder. I think another challenge with adolescents is they're exploring, especially with diet. They'd like to be social. It's very hard to be social. It's hard to, and this is for adults too, to be that person who's like, oh, let's meet up at this restaurant, or can we eat here? That's a safe place for me. And I remind them, do not undervalue your esophagus. If this is your medication. So if you were meeting someone and you said, I have to go pick up my medication on the way, I'm going to be 10 minutes late, they would never have an issue with that. And so trying to change or alter your lifestyle for your health is very, very valuable. And I think that people will respect that. Patients don't want to feel like a burden or like uncool, right? But I think that it's very important. I also say things like, if this was your heart, right, you would take it very seriously. Your esophagus is just as important. So I think that really remembering and acknowledging their disease is important.
Absolutely. What have we not touched on that you think it's important for people to know about transition of care?
I think that remembering that it's not easy, right? It's not simple for anyone. And I think it's normal to have these challenges, like the slide where, the first thing is normal adolescence as a barrier. This is expected. It's a process. And I think that as long as you do your best, that's all we can really ask for. But it's certainly a challenge. You will get through it. And once the patient is transitioned, just remember to continue being there as that support person while allowing them to take ownership of their healthcare. Even just checking in, I think, goes a long way in making them feel supported.
Um, We've got one final question for you. What requests or tips do you have for the pediatric providers when they are transitioning patients to the adult provider? What can they do to help set their patients up for success?
Yeah, I think the pediatric providers do a really great job, but just reminding them of, the basics of what we talked about, reminding the patient that they are going to have patient-centered healthcare, take ownership of when their meds are due, when their refills are, having your own EMR, your own medical records ready, and understanding your disease, but also, a little, I always tell patients, the GI adult providers were pretty nice, but it's not as colorful in the adult hospital. You can bring your stuffed animal, but it's not as common. Things are going to be different, and just mentally preparing them for knowing that it is different, but it'll be okay. And just because I think sometimes patients come in, they're like, well, it'll be mostly the same. No, it's very different. So just mentally preparing them for that change, I think, is important as well.
Well, thank you so much for your time and your commentary and the research that you shared today. We really appreciate all the information about transitioning care from pediatric to adult providers.
Thank you so much for having me. This was wonderful.
Absolutely. Well, thank you also to our education partners for their support of this webinar series, including Bristol Myers Squibb, GSK, Sanofi, and Regeneron. You can continue learning more about eosinophil-associated diseases by attending our additional webinars. Stay tuned. We're about to open registration for one about building your EOE care team that'll be held on December 14th. You can also listen to and subscribe to our podcast called Real Talk Eosinophilic Diseases. In our latest episode, we talked with a allergist who is not only an allergist, she's also a person living with eosinophilic gastritis. It's a really interesting conversation that we hope you'll take a listen to. You can find it at apfed.org/podcast, as well as on Apple Podcasts, Spotify, Audible, and more. Another great opportunity to learn about eosinophilic disorders is our annual patient education conference, EOS Connection. This year's conference was held in Denver, Colorado, and while the live events happened in July, the recordings of the presentations are now available on demand at apfed.org/conference. In fact, APFED members can register for virtual access for free. In fact, we sent out an email earlier today, so check your email for that access code. Finally, we encourage you to continue the discussion started today in our online community on the Inspire Network. It's a great place to connect with patients and caregivers for support. Check it out at apfed.org/connections. Thank you again for joining us today for APFED's EOS Support webinar series. If you have any questions that didn't get answered today, please email mail@apfed.org. I hope you have a great afternoon.